Hello and welcome to you all. My name's David Vo. I'm the Deputy Director here at the Walter and Eliza Hall Institute. And it's great to see such a good turnout on such a cold, wintry night. Now, I'd like to remind you that this event is being live streamed, and so it's been videoed, and it will be available on the Walter and Eliza Hall website if you miss anything or you want to be reminded of what's being said. And can I also ask you to please turn off or turn to silent your mobile phones. Now, this public lecture is being held on the land of the Wurundjeri, and I'd like to acknowledge the Wurundjeri people who are the traditional custodians of this land. I'd also like to pay my respect to the elders, both past and present, of the Kulin Nation, and extend that respect to other Indigenous Australians present. Now, at the Walter and Eliza Hall Institute, our main theme of research is diseases associated with the blood cells, whether that's development of red blood cells and white blood cells, the functioning of the immune system, which leads into autoimmune diseases and also infectious diseases such as malaria. And the research you're going to hear about tonight touches on a couple of areas of research here at WEHI. You're going to hear from some very eminent rheumatologists, and they're interested, of course, in diseases of bones and joints, and that also interacts with our interests in the immune system and also development of some of the hormones that regulate growth of red blood cells. Now, our first speaker tonight is going to be Professor Ian Wicks. He's an NHMRC Clinical Practitioner Fellow, and he's head of the Inflammation Division at this institute. He's also the Professor and Director of Rheumatology at the Royal Melbourne Hospital and the University of Melbourne. Ian did his medical degree and physician training in Sydney, and he then completed his PhD here at the Walter and Eliza Hall Institute, and after that worked in the United States for a while and then returned to Melbourne. His major research institute is in rheumatoid arthritis, and he will tell us about that tonight. Thank you, Ian.
So thanks, David, and I'd like to add my warm welcome to everyone this evening. Thanks for coming. And I guess we should start by saying that arthritis is a very big topic, and we can't cover everything. So we thought we'd focus on two of the most common types of arthritis and try to give you an overview of those two important areas. And as David said, my major interest is in rheumatoid arthritis, so I'll be concentrating on that. And then our second speaker, Professor David Hunter, in the second half of the symposium will talk to you about osteoarthritis. So before getting into rheumatoid arthritis, just some broad brush statistics about the problem of arthritis. And this is very common, and a report from 2007 estimated that over 3.5 million Australians suffer some form of arthritis. The majority of that is osteoarthritis, but a very significant number also suffer with rheumatoid arthritis. Arthritis is actually more prevalent in women than men, affecting nearly 20% of women. In contrast to some of the general preconceptions about arthritis, it actually affects many younger people. And over half of patients with arthritis are actually in the working age population, so less than 64. So it's not just a disease of the elderly, and it's very expensive. So in 2007, the allocated health system expenditure from government was over $4 billion. That's just a fraction of the actual cost in terms of personal and societal costs when you think that a lot of these people are unable to work, for example, because of their arthritis. So there's costs associated with that. And in fact, most of the costs are actually borne by the person with arthritis and their family. Now, all of this is only going to get worse as the population ages, and we have problems in our community, obviously, with the obesity epidemic. Arthritis is likely to get worse and to cost the community even more. So as a result of a growing awareness of the size and importance of this problem, there have been some government initiatives. So in 2002, arthritis and musculoskeletal conditions was officially recognised, if you like, by the NHMRC and the Commonwealth Government as a national health priority area. And that puts it up there with diseases like cancer and heart disease. So I think that was a very important political step in raising awareness in this area. The World Health Organization also sponsored the Bone and Joint Decade from 2001 to 2010. You may not have heard a lot about that locally, but internationally it was, I think, a very important initiative in raising awareness and promoting research. So, what about rheumatoid arthritis? This is a complex disease. It's impossible to obviously cover everything. But I just want to give you a bit of a Cook's tour, I guess, of major features of the illness. It's common. So about 1% of the population, anywhere you look really, in the world, is affected with rheumatoid arthritis. It can occur at any age, from young children through to the elderly, but typically it comes on in the early adult years, so in people's 20s, 30s, 40s. And it is a condition that tends to be lifelong. It's more common in women than men. The sex ratio is 3 to 1, females to males. The condition is driven by autoimmunity, and I'll say a bit more about that in a few slides. But essentially, in this condition, the immune system, which is geared for the protection of the body against infection, turns traitor, if you like, and it recognises the joints as something foreign and mounts an immune attack on the structures of the joints. This gives rise to joint inflammation, which is chronic and persistent. It lasts typically for decades, and that leads to progressive joint damage. So synovial joints are shown here, highlighted in the glowing skeleton, are the target of this autoimmune attack in rheumatoid arthritis. But the disease very characteristically has extra-articular features, and by that I mean a range of problems occurring outside of the joints. And one of the most significant of these is cardiovascular disease. And in fact, patients with rheumatoid arthritis die significantly earlier than their peers. And the major reason for that is accelerated atherosclerosis. So patients with rheumatoid arthritis have more heart attacks and strokes and die of that cause. And it appears to be an interaction between the inflammation that's occurring within the joints spilling over to exacerbate atherosclerosis and cause this premature mortality. So, what is a synovial joint? This is the structure that's the target of the immune response, the abnormal immune response in rheumatoid arthritis. And this is a cartoon of such a joint here. These are the joints that allow us to move. So the reason that you're able to sit down and bend your hips and knees, write with a pen, is because this is a specialised structure that allows you to move the ends of bones against each other. And that's achieved by having the bones here lined by a low friction cartilage surface. There's a capsule surrounding the joint, and on the inner lining of that capsule is a layer of cells called the synovial lining layer. That secretes fluid into this joint space here that contributes to this low friction environment that allows the joint to move smoothly, and normally we take this entirely for granted. So what happens in rheumatoid arthritis? Well, the architecture of this specialised structure changes dramatically. And we have activation of the cells that are normally resident within the joint. So they're cells like chondrocytes, the cartilage cells, bone cells, the osteoclasts. And we have invasion of this compartment in the body by inflammatory cells that Professor Vo mentioned, deriving from the immune system, from the blood system. These cells don't normally traffic into the joint, but they pour into these inflamed joints in great numbers and cause joint inflammation. Now, over time, that destroys the architecture of this compartment, so you get bone and cartilage destruction. And for the patient, that equates to chronic pain, joint stiffness, loss of quality of life, and progressive disability. So what does a person with rheumatoid arthritis experience? This is a person with the earlier stages of rheumatoid arthritis, and you can see that multiple small joints tend to be involved. So these are the joints, the knuckle joints, and they're swollen, and this person would complain of pain and stiffness in those joints. Typically, the stiffness is of early in the mornings, and this can be very disabling, so that people have difficulty getting dressed, making breakfast, getting ready for work, etc. Can become major problems. There's wasting of the muscles of the hands, shown with this exaggerated furrowing on the back of the hands through disuse. The muscles waste because joints are painful, there's local inflammation, so the person becomes weak and can have trouble using their hands. Rheumatoid arthritis is very characteristically symmetrical like this. So a symmetrical small joint polyarthritis, as we refer to it in the clinic, so involving multiple joints in a symmetrical fashion, is the characteristic presentation of rheumatoid arthritis. So what would we see if we could look into such a joint? And this can actually be done with an arthroscope. So this is the equivalent of keyhole type surgery. You can get an arthroscope and actually place it into one of those inflamed joints and have a look. If the joint was normal, this is the sort of appearance that you see. So things are smooth, there's a lining of the synovium shown here. Nothing is going astray. In rheumatoid arthritis, this is the synovial lining here becoming inflamed. You can see the dilated blood vessels, the tissue's red and inflamed. And over time, this is what happens. The tissue overgrows. It has this frond or villus-like appearance. And some people have even compared this growth of the synovial tissue to a localised form of tumour. It's not a tumour, it doesn't have any of the other features of a cancer. But in a local sense, it's very destructive, invasive, destroying cartilage and surrounding bone, overlying tendons, and behaving in many respects like a localised form of tumour. What would we see if we took a biopsy of that inflamed tissue? And it's a little bit hard to show you a normal, but if you just look up here, this shows you a normal human joint. You can see the surfaces of the bones. This is the smooth articular cartilage. And the lining of the synovium is just tucked away down here. It's normally just a very thin little lining of tissue on the inside of the joint capsule. If the patient has rheumatoid arthritis, this is the appearance we see down the microscope. So this is a dramatic increase compared to the normally thin layer of synovial cells. The synovial tissue is infiltrated by lots of inflammatory cells. There are these dots here. Blood vessels are more prominent. There's a proliferation of cells, and this is an inflamed, massive tissue that burrows into surrounding structures and compromises the normal anatomy and function of the joint. What do we see if we take X-rays? And this is a very standard way of monitoring patients, is to to take X-rays over time, and this is a series of X-rays taken of the knuckle joints in a person with rheumatoid arthritis in the earlier stages and as I think it's a year or two apart here. And if you just look at this joint space that we're talking about, this is where the gap between these two bones is lined by the articular cartilage. The synovial capsule is on either side here, and this is the compartment that we're talking about. Over time, it starts to narrow as the cartilage is destroyed. And you can see here with more time that the bones are starting to look mottled. The joint space has narrowed considerably. If you just look at the distance between those bones, that is a reflection of destruction of the underlying cartilage. There are little pockets of bone that have been chiselled out here, and this is a large area of bone that's been whittled away by the local inflammatory mass of synovium. So what happens over time? And this is what happens if the disease is not treated, and it's really a dreadful progression of problems for the patient. So these are the early sort of stages that I've been telling you about. This is as disease progresses, and this is what has happened all too often in the past for patients, where basically the joint is destroyed. Bones are whittled away, normal functioning of this specialised compartment is lost, and the patient becomes profoundly disabled. And so this is what we always do our best to try and stop when we see patients with rheumatoid arthritis. And we can stop it, and we know that our best chance of stopping it is to intervene early. So a very big push in recent times in conjunction with this sort of awareness-raising initiatives that I mentioned earlier on is to get people to medical attention much earlier than in the past. And if you look at the course of a patient over time here, and this is the start of their symptoms, so a person coming along to their GP with pain and stiffness in their joints, maybe not feeling well in a general sense, with fatigue, lethargy, very common way for patients to present. If their disease is not recognised, if it's not effectively treated, this is the natural course over time of progressive joint destruction. And that's the patient who I've just shown you. If we can intervene quickly and effectively suppress the joint inflammation, this is the sort of ideal course that we aim for, that there's very little progression. The patient's symptoms are controlled, damage is minimised, and quality of life is maintained. Unfortunately, that's not the typical picture. We normally see people down the track. This can be a difficult disease to diagnose. So we might see our average patient more along this time point. If we can institute treatment, we can still achieve a lot and prevent this progressive joint destruction and progression to severe disability. So this is the part of this spectrum that we're very much aiming for when we treat rheumatoid arthritis, and we know that if we don't see patients until later, that the outcome's much worse. So what causes rheumatoid arthritis? Well, this is a sort of discussion all on its own. But just to give you a kind of general view of what people think, because we don't actually know what is the actual cause of rheumatoid arthritis, and there may be more than one cause. As I mentioned, we know that the immune system is critically involved, and it turns traitor in the sense that it starts to attack the body's own components rather than fighting off infection from the environment. But if you think of these three major pathways, it can be helpful, I think. The first is so-called innate immunity, and that's the part of the immune system that's geared for sensing and recognition of abnormalities. So if you have a viral infection or a bacterial infection, these are the cells that will respond, whether they're in your respiratory tract, in the throat or in the lungs. And there are similar sorts of cells in the joints. And you know that if you've had influenza, for example, it's very common to have achy, stiff joints for a while after you've had such a viral infection. But normally that's transient. It's temporary and the body recovers. But in rheumatoid arthritis, what seems to happen is that persists. So perhaps there's some sort of initial insult, perhaps a virus, that doesn't get cleared or that damages the joint compartment in such a way that the so-called adaptive arm of the immune response recognises these components as foreign. So that might be something like type 2 collagen. That's a constituent of joint cartilage. And it seems that in a genetically predisposed individual, so somebody with the right genetic makeup or the wrong genetic makeup, I guess, this is recognised by the adaptive immune system. And the adaptive immune system involves the cells that have specificity and memory. So these are the cells that make antibodies, the so-called B cells, or the T cells that recognise short stretches of peptides derived from a virus, for example. These cells are switched on to now recognise components of self and mount an immune attack against that. They interact with the cells that are resident within the joint structures, so these are these cells shown over here, and they over time start to activate these resident cells. So these are the chondrocytes in cartilage, the bone cells, the synovial cells lining the joint compartment become activated, and they're switched on to a remodelling program. So it's as if the immune system is saying, look, there is something wrong here. It needs to be dealt with, it needs to be cleared. Let's do whatever it takes to get rid of it. And it activates these cells and they start chewing up the local structures. So how do we treat rheumatoid arthritis? Traditionally, the disease has been so difficult to understand in spite of over 100 years of inquiry. A lot of the traditional drugs were actually just introduced empirically. They were used for some other purpose and found to be of value in rheumatoid arthritis, and so entered clinical practice. Gold, for example, so this dates back to over 100 years when we didn't have effective antibiotics. Gold, heavy metals like gold were used as antibiotics. And it was found in treating patients with conditions like TB, for example, that if they had rheumatoid arthritis, that the rheumatoid arthritis improved with injections of gold. That shows you the state of the art at the time. Methotrexate, an anti-cancer drug that serendipitously was found in patients with rheumatoid arthritis, treated in much, much lower doses than we would normally treat a cancer, that their rheumatoid arthritis improved. So gets adopted and is still in clinical practice and in fact is the mainstay of treatment in rheumatoid arthritis. So these are the traditional sorts of drugs, and they're called disease-modifying anti-rheumatic drugs, or DMARDs for short, because they've been proven to modify the course of the disease. So they don't just make people feel better, the joint destruction is diminished. Non-steroidal anti-inflammatory drugs, on the other hand, tablets such as naproxen, Voltaren, etc., make people feel better. They help temporarily with inflammation, but they don't modify the underlying course of the disease, so they're not disease-modifying. Corticosteroids, likewise, probably aren't disease-modifying. They're useful for alleviating symptoms short-term. So I guess a big advance in the last 20 years or so has been the recognition that in spite of this incredibly complex scenario for rheumatoid arthritis, that there are some Achilles heels, and that these arms of the body's response talk to each other through chemical messengers called cytokines. These cells communicate to each other by making usually proteins that travel between different cells and send signals. And we know a lot more about these cytokines. Now they've been characterised, given names and studied intensively, and we're now actually able to take mainly antibodies that I mentioned produced by the normal immune system and manufacture them in a way that they will block these cytokines. And this is shown here. This is a cytokine shown here as this bullet-shaped object docking to its receptor on the surface of a cell. So that's the normal lock and key type mechanism that a cytokine operates by. When it binds to its receptor, it will deliver a signal to that cell to respond, to behave in a certain way. That's how cytokines mediate their effects. You can neutralise that by either engineering a soluble form of this receptor so that it floats free of the cell and can't bind into the cell wall and deliver a signal, or you can block it with a so-called monoclonal antibody that will prevent the cytokine from docking to its receptor. Now, one of the most important cytokines has a name called tumour necrosis factor, and that has a history that's a little bit too detailed to go into, but it's called tumour necrosis factor because it was found to cause shrinkage of tumours in experimental mice when given in very high doses. That cytokine turns out to have a very important role in rheumatoid arthritis. It's called TNF for short. It's a naturally occurring hormone, if you like, in the body, and at low levels it promotes inflammation and that helps the body heal. At higher levels it makes you very sick, and patients with septic shock in intensive care, for example, will have very high levels of TNF, and it causes major system shutdown for the body in that scenario. So it's something that needs to be very tightly regulated. Now, we're now able to block TNF, a tumour necrosis factor, very specifically with monoclonal antibodies and soluble receptors that bind TNF. And in rheumatoid arthritis, this turns out to be very, very effective. This can be packaged up as a pen with an injection. The patient can be taught to give that injection themselves, just like a diabetic. And it's really been a very exciting development and a major step forward for patient care. Exciting as it is, it doesn't. It's not a cure. It doesn't fix everyone, and there are many patients who unfortunately fail to respond. It turns out that so as a result of that, we're very interested in new targets such as TNF, and there certainly is a list of those that we and many others around the world are exploring. It turns out that TNF is involved in other rheumatological conditions, and blocking it with these monoclonal antibodies is of value in conditions like psoriatic arthritis, ankylosing spondylitis, as well as some non-rheumatological conditions shown here. And these have now entered clinical practice, and it's been a very exciting development. So I just want to finish by indicating one of the new potential therapeutic targets. David touched on this in his introduction, that the Institute here at WEHI has been interested for many years in blood cell production. And some of the hormones that drive blood cell production from the bone marrow, from stem cells in the bone marrow to produce the mature blood cells that circulate around and do their job in the blood, some of those hormones, or cytokines if you like, are now very well understood. They've been characterised, and we're now actually able to make monoclonal antibodies that even block them. So we've been very interested in the possibility that these cytokines or hormones that drive blood cell production might have an extra role in inflammation, and they might promote inflammation. And so we've been exploring blockade of those blood cell producing cytokines in experimental models, and this shows you one of those models here. We can't do these sort of experiments obviously in humans, so we have to resort to experimental mice, and they're very elegant systems to work with because you can manipulate so much of the experiment. And this is a mouse that's genetically lacking one of these cytokines called GM-CSF, and this mouse has been made artificially in such a way that it has no GM-CSF whatsoever. The gene has been removed. It grows and develops normally, however, in spite of that, so we're able to put it through experimental models of arthritis. And the details aren't really important here, but if you compare such a mouse lacking the GM-CSF gene during one of these experimental models of arthritis. This is shown over the passage of time here during this experiment as these open circles, compared to a normal mouse showed in the closed circles with arthritis progressing throughout the experiment. This mouse lacking GM-CSF is profoundly protected. And as a result of experimental results such as this, we've developed a program where GM-CSF is being targeted in rheumatoid arthritis, and that has now progressed through to human clinical trials. So to finish up, rheumatoid arthritis, a common chronic inflammatory joint disease targeting synovial joints caused by an aberrant response of the immune system causing autoimmunity, persistent inflammation, local joint damage, as well as extra articular complications outside of the joint. Lots to be excited about in terms of future or current and future developments. We know that early diagnosis, early treatment is vital to long-term outcomes. The earlier the better. We have very clear-cut goals now in rheumatoid arthritis. When we didn't have so many effective agents, it was hard, but it's much better now, and we aim to rigorously suppress features of the disease in a goal-directed way, and to change treatment if we're not achieving effective suppression of disease. We have this exciting new era of cytokine blockade that's now entering clinical practice. Might allow us to understand different types of rheumatoid arthritis in much finer detail than we've been able to in the past. But clearly there are still great challenges. We need to understand this disease much better. We need better markers of what's actually going on. And I think there's great interest in developing even better treatments in spite of the advances that we've had. And we would certainly look forward to the era when we can personalise our treatment of rheumatoid arthritis. So I better stop there, and thank you for your attention, and hand over to David.
So you'll all have an opportunity to ask Ian and our next speaker, David Hunter, some questions after the second talk. I'd also like to mention that a lot of the work in characterising the colony-stimulating factors, the CSFs that Ian mentioned, was carried out here in the laboratory of Professor Don Metcalf. And one of the champions that pushed for development of agents that block TNF in the treatment of rheumatoid arthritis was Mark Feldman, who performed his PhD here at the Hall Institute under Professor Gus Nossel. So the next speaker is going to be Professor Hunter. He's the Florance and Cope Chair of Rheumatology and Professor of Medicine at the University of Sydney and the Royal North Shore Hospital. David gained his medical degree and Masters in Sports Medicine at the University of New South Wales. He then completed his physician training and earned a Masters of Medical Science in Clinical Epidemiology from the University of Newcastle. He then received his PhD in 2001 and went over to the United States, where he was at Boston University until he returned to Australia in 2010. Professor Hunter's research is focused on osteoarthritis, and he will tell us about that tonight. So thank you very much, David.
Thanks very much for the introduction and the opportunity to be down in this beautiful part of the world. It's always good travelling to Melbourne, beautiful city. And thank you very much to Professor Vo and Professor Wicks, Maureen and the team from the Walter and Eliza Hall. I'm going to talk to you about osteoarthritis. I'm going to reiterate some of what Ian has already said about the prevalence and the impact of the disease, because I think it's really important to highlight that. And I think as I look out there at the population of people in the audience, I'd be very surprised if many of you didn't have this disease. My primary means of support is on an Arthritis Research Council Future Fellowship. And for those of you who are medical, who like looking at medical literature and who want to look at something again afterwards, about what I'm talking about, because I'm talking too quickly for you to understand, there is some literature there that you're welcome to look at. And as I understand it, the slides will be posted on the website. This is really what I want to talk about tonight. I want to talk about the burden of disease because many of you probably experience this, and I just want you to get a sense of how that impacts our community. I want to talk about how it's currently managed and the problems within that. I want to talk about some of the challenges we face in terms of trying to reform the way that's currently managed, and then look at ways we're trying to do with regards addressing the appropriateness of care, but also some research opportunities that are out there that hopefully will make a big difference to this disease in the future. Now, firstly, osteoarthritis is a disease of the whole joint. When I went through medical school not that long ago, well, that's probably a long while ago, but the reality is it was very much a cartilage-centric disease by definition, okay? The definition has changed dramatically over the last 10 to 15 years, where we really conceptualize this as a disease of the whole synovial joint. So it can affect any tissue within the joint, of which cartilage is a constituent, and it can affect the cartilage, but I think it's important you understand cartilage does not contain nerve fibers, so it can't be responsible for the pain that you experience. Whereas a lot of the other tissues around the joint, particularly the bone, the capsule, the synovium that Professor Wicks was talking about, the muscle, and those other tissues are much more responsible for the symptoms that you may feel. And ultimately, as a clinician, the pathology, whilst it's important, is not as important as what you experience. And it's really, from a clinician standpoint, it's that pain and that functional limitation that you experience and that disability that we need to focus on as clinicians. Now, when you look at these slides, you probably think, gosh, he's going to talk about mortality, and he's going to talk about that in relation to osteoarthritis. Well, in part. The reality is, over the last 40 to 50 years, our mortality has improved greatly, largely by virtue of improvements in treatment of cancer and heart disease. Many of those advances have probably happened here at Walter and Eliza Hall. And by virtue of that, our life expectancy has improved dramatically. And you all think that's probably a wonderful thing. The reality is, though, unfortunately, during that same interval, the period of which we have osteoarthritis is now growing for longer because we're living longer. So in 1990, the median age of diagnosis of osteoarthritis was about 69. So that's the age at which the disease was typically diagnosed. In 2010, the median age is now about 56. So it's come forward a lot in terms of a person's longevity. And it's not by virtue of anything we're doing necessarily any better in terms of diagnosing the disease. This is largely by virtue of societal changes. So these are changes that are happening as we see it with regards particularly obesity and overweight in the community, but also increasing rates of joint injuries that are happening throughout our community that are driving earlier presentation of osteoarthritis. So again, life expectancy and increasing life expectancy for many people is a wonderful thing, but when you look at the fact that the median age of diagnosis is now 56, that means the average person who is diagnosed with osteoarthritis is now living with that for about 30 years. So it's very much a chronic disease. And for many people who have osteoarthritis, it's that pain and ongoing disability for that long period of time, which is quite troubling. As Ian said before, about 1 in 8 Australians have osteoarthritis. So it's an incredibly common problem. It's about 3 to 4 million Australians have this disease. So when you look at the diseases that are out there, this is one that is incredibly common throughout the community. So we already know it's common, but we expect within the next 10 to 15 years that 3 million will likely double by virtue of those 3 factors. Increasing obesity in the community. Sorry, it's David. I'm a huge fan of David and Michelangelo and those folks, but I've disfigured him here for the purposes of the talk. Aging, and also, you probably don't know this fella, but this is Quade Cooper. He's a rugby union player. He plays north of the border. But he tore his ACL last year during the World Cup. Okay, so it's these 3 factors, obesity, increasing aging, and increasing numbers of joint injury that are likely to lead to a doubling of the number of people that have osteoarthritis within the next 10 to 15 years. So there's already a lot of Australians that are affected, but we haven't seen the start of it yet. For the average person that has osteoarthritis, this has a huge impact. So 2 in 3 patients with osteoarthritis, the last time they were pain-free was over a year ago. It's a long time to live with pain. 2 in 5 patients felt that there was a pain, that the pain was like a knife being stuck in between their bones. So obviously it has a huge personal impact. From a societal standpoint, another way that we measure this is by the healthcare costs and burden. As Professor Wicks mentioned, one way we measure that is through direct healthcare costs, which is what this slide's going to talk about. Another way to look at that is through indirect costs, and that's by far and away the biggest cost related to arthritis, largely by virtue of work disability. But these are direct healthcare costs. So if you live in America, about 18% of your GDP is spent on healthcare. It's about 8% in Australia, and our healthcare outcomes are probably as good as they are in America. But still, about 10% of all of our healthcare dollars are spent on musculoskeletal diseases. About 5% are spent directly on osteoarthritis. And that appears to be going up about 10% every year. Now, Julia and Kevin and Tony and all those guys are very worried about the economy. They're not worried about this disease, unfortunately, but because the number of people with this is going to double over the next 10 to 15 years, the tsunami, the epidemic that Professor Wicks spoke about, really hasn't hit our economy. So every year, about 5% of our healthcare dollar is spent on osteoarthritis. About 0.05% of our research dollars is spent on osteoarthritis. Again, that's my agenda, but anyway. So it's an incredibly common source of pain, it's incredibly prevalent in our community, and it costs a lot of money. So what are we doing about it? Well, one way to deal with it is to replace all those joints out there that have osteoarthritis. Not necessarily sensible, but that's one way to look at it. So this is a slide from US data, projected from 2010. They're doing close to 1 million joint replacements a year. In Australia, we do about 80,000 joint replacements a year. These are projections which were done by an orthopedic surgeon, projecting out that they're going to do about 3.5 million joint replacements a year in 2030. They don't have the economy to support that, they don't have the number of surgeons that will actually substantiate that, and I don't necessarily think from a public health perspective that's the best way to deal with this problem. And if I talk to patients, most patients would prefer pretty much to do most other things other than surgery. It's not belittling joint replacement. Joint replacement for the person that needs it is a wonderful procedure, but it's not the way to address this problem. Most people with osteoarthritis have more than one joint affected. So to replace serial joints at a cost of about $20,000 a piece is not necessarily the way we should be dealing with this problem in the general community. Now, Sir William Osler is one of the grandfathers of modern medicine. And this was his attitude towards osteoarthritis. And by and large, that's changed. By and large. It's improved a bit. The reality is, though, for many GPs that are out there, they find this disease enormously frustrating because they don't necessarily feel that there's a lot that they can do for the individual patient with this disease. So I spend a lot of my time talking to GPs and other health professional groups to try and engage them in a dialogue where they can understand that there's a lot that they can do. So usually the first port of call for a person with osteoarthritis is their GP. What I'd really like GPs to understand, if there's any GPs out there, is there's a lot that we can do for patients with osteoarthritis, but I understand your frustration and that there's not a lot that you can do within the 7 to 10 minute consultation. We're doing a lot of things right now with GPs to help facilitate coordinated management plans and help facilitate increasing awareness of the disease, and I'll come back to that in a minute. All right, but like every researcher, you have to remain optimistic. There's always something good coming down the pike. So that's where I currently sit. By and large, what we typically would advocate for the average person with osteoarthritis is that we should start with non-pharmacologic management modalities. So that's weight loss, exercise, use of assistive devices, modifications to shoes, canes, things of that nature. When they're not working any longer, then we'd start off with analgesic medication, usually in the form of paracetamol or anti-inflammatories. And when they're not working any longer and you have persistent pain or limited function, then surgery becomes an option. About 80% of management of patients with osteoarthritis in Australia consists just of this. By and large, we ignore this opportunity. It's a missed opportunity because it makes a potential difference to the course of your disease long term. Again, bear in mind that we're not usually just talking about one joint. We're usually talking about a few joints, a hip, a knee, a hand. And the reality is, unless you address the underlying reason why you've developed osteoarthritis in the first place, these aren't necessarily going to be the answer for all of your joints. So it's really important we try and address the non-pharmacologic options as well. So there's a big disconnect between evidence and what we see in practice. Now, I've been fortunate to be involved in developing a couple of international guidelines for the International Academy and the American Academy of Orthopedic Surgeons. And these are wonderful documents, But again, they're documents and they don't necessarily get translated into evidence. So these are guidelines, recommendations about how osteoarthritis should be managed. The other challenge with them is that they don't necessarily talk about the individual patient who presents to me as a rheumatologist. So you always have to translate those guidelines into a clinical circumstance that's appropriate for that individual. But again, by and large at the moment, guidelines are not necessarily reflective of what clinical practice is. So here's one of the problems we currently face and the challenges we see with the management of osteoarthritis is what we call the silo approach. So for many of you out there who have osteoarthritis, you've probably seen any one of a number of these health professionals. Many of them give you very different messages about the way to manage osteoarthritis. They don't typically talk well to one another, so you often end up as the confused person in the middle with mixed messages. And you wonder to yourself, what is the answer? The other big challenge with osteoarthritis is the comorbidities. So these are diseases that you also have at the same time as your osteoarthritis. By far and away the most common is overweight and obesity, which happens in about 90% of our patients with osteoarthritis. Hypertension happens in about 60% of patients, as does back pain. Depression occurs in about 30% of our patients, diabetes in about 20%. And oftentimes when we manage patients with osteoarthritis, we administer things that don't necessarily make these other comorbidities better and potentially make them worse. So it's really important for the management of your osteoarthritis that you try as best you can to focus on management opportunities that can also help these other comorbidities if they're present. We know from the CareTrack study, which came out relatively recently in the Medical Journal of Australia, that the management of osteoarthritis, if you compare it particularly with coronary artery disease, ulcers, heart failure, osteoarthritis sits down here. So the majority of patients who have osteoarthritis do not receive appropriate care for their disease. Again, as compared with other very common and again, potentially mortal diseases. But the reality is this is much more common, much more expensive, and the most patients in our general community don't receive appropriate care. One of the big problems that I see is that we don't necessarily engage other professionals who can help with the management of osteoarthritis per se. So again, most patients with osteoarthritis are overweight or obese. They're often sedentary or they have muscle wasting around the joints themselves. So engaging with health professionals, particularly physiotherapists, dietitians, exercise physiologists who can help in the management of that, would actually help with many of the problems that happen as part and parcel of osteoarthritis. But unfortunately, only about 4% of people with osteoarthritis are actually engaging allied healthcare professionals. And most patients with osteoarthritis, despite being overweight and obese, don't necessarily do anything about trying to lose weight. So these are big opportunities that are being missed as far as management's concerned. This is a bit of a complicated slide, and I apologize for that, but I'll take you through it. The measure, the unit estimate here is a thing called the effect size. So an effect size of 0 means we can't tell it apart from a placebo. Okay? So if the number in the brackets, or the number here, is 0 or less, it means we can't tell it apart from a sugar pill or a sham procedure. Now, if anybody here is using paracetamol, I don't want to belittle what you're doing, all right? But the best evidence would currently suggest the effect size for that is negligible, meaning that from a pain relief perspective, we can't necessarily tell it apart from a placebo in well-done trials, in contrast to anti-inflammatories. So again, a side effect profile, these are probably not as safe as these, but from an efficacy standpoint, these are much more efficacious in terms of relieving the pain. So I just want to highlight that one. And the other one I want to highlight is this one. About 100,000 Australians every year have an arthroscopic procedure done on their knee for osteoarthritis. The best current evidence would suggest that makes patients worse. Okay? So if I compare that to sham arthroscopy or physiotherapy or some other meaningful intervention, typically that's making patients worse. There are rare instances where a patient's knee is locked or unable to fully extend, where an arthroscopy may be suitable. Outside of that, this is not making patients better. It costs our healthcare economy about $500 million every year. So a big problem we have in osteoarthritis is that of the placebo, okay? And again, I should introduce these slides and preface them with an apology first. Again, if you're on glucosamine and it's working well for you, don't stop it, Okay, it's cheap and it's safe. But the best current evidence would suggest that most of the treatments that are on this slide are no different from a placebo. Okay, that includes, this is a really emotional picture which sees a patient down on bended knee, and it's basically an advertisement for Synvisc, which we can't tell in well-done trials. We can't distinguish that from the use of intra-articular salt water. Again, the use of arthroscopy is no different from a sham arthroscopy or physiotherapy. So again, from the viewpoint of cost and safety, you can see that there are benefits to be had in other forms of treatment, which is where I want to go now. So this probably sounds a little bit pejorative, but from my perspective, the way we currently treat osteoarthritis is what I would categorize as palliative. We treat people with analgesic medication, and when the joint's not working any longer, we remove it. There are lots of opportunities, as Professor Wicks was saying, that we can impact from the viewpoint of progression. And that's where we're going with much of the research that we're doing. We're going into an area we call disease modification, so hopefully slowing and or reversing the structural changes that go on within the joint. But there are opportunities for you to do that right now if you have osteoarthritis, and I'll come back to that. This is another huge opportunity missed. For knee osteoarthritis, about 70% of the reason why people develop this in the community relates to obesity and joint injury, both of which are eminently preventable. We don't do anything about preventing that from a public health perspective in our community. From a clinical standpoint, what I usually would advocate is that every treatment management plan for a patient with osteoarthritis needs to be tailored to the person who has the osteoarthritis. So if you have an alteration in the alignment of the lower extremity, then a brace might be an option. If you excessively pronate your foot, then having motion control shoes may be an option. If you're overweight or obese, then weight loss is an option. So all of the treatments that I'm going to talk about aren't necessarily suitable for everybody. So it depends upon what you present with. This is a trial that we've recently just finished of 350 overweight and obese people with symptomatic knee osteoarthritis. Over the course of 18 months, through a combination of diet and exercise, we got them to lose about 10% of their body weight. During the same interval, their pain improved by 50%. So again, overweight and obese people with symptomatic knee osteoarthritis lost 10% of their body weight through diet and exercise. 50% improvement in their pain through a combination of diet and exercise. That outstrips anti-inflammatories any day. It's more challenging from a behavioural perspective, but a lot of people with osteoarthritis who are overweight and obese say this can't be done. This is proof that it can be done. A lot of patients with osteoarthritis also will say that we can't exercise because it hurts too much to run or to play tennis or to do basketball. I'd really encourage you, if you have osteoarthritis, to do exercise, and ideally a combination of strengthening as well as aerobic cardiovascular type exercise, typically focused on low impact style activities. So it's really important to do that, both from the perspective of strengthening the muscles around the joint, but also facilitating weight loss. This is one of the more difficult slides I have to show, and you look at that and you just say it's a simple bar graph. What's he upset about? The reality is these are people who we've seen over the last 12 to 18 months in various centres throughout New South Wales, most of whom are on the orthopaedic waiting list for a knee or a hip replacement. We've just started a conservative management program to try and instill appropriate conservative management for those people. It basically demonstrates that about 80% of people who are on the orthopaedic waiting list for a knee or a hip replacement have never had any conservative management for their osteoarthritis before being put on the wait list for a knee or a hip replacement. It tells a bit of a problem about the way we deliver healthcare. So if you look at the why people develop osteoarthritis, about 45% of it is related to obesity. About 15 to 25%, 15% in women, 25% in men is related to joint injury, both of which are eminently preventable. When I talk about injury prevention, because I think a lot of people are surprised that you can prevent injuries. Most injuries that occur to the cruciate ligament, this stabilizing ligament within the knee, occur non-contact. So it's largely by virtue of a person pivoting on their knee and the knee going in at an angle like that. So what's being depicted here. All you need to do is basically to train people to learn how to land on their leg properly. About 20,000 Australians every year tear their cruciate ligament. 70% of those people will develop osteoarthritis within 10 to 15 years. ACL reconstruction does not change that risk. Okay, so even if you've had it reconstructed, it's not going to change that risk. Much better to prevent these. Another area that we're working on is to try and identify what tissue structure changes first. The reality is many people believe this is all about cartilage. I don't. And this is a research effort to try and find out what is the tissue structure that ultimately is changing first. So we're doing a study within the Osteoarthritis Initiative to try and identify what tissue structure predates the development of Xray osteoarthritis. Is it a change within the bone? Is it a change within the cartilage? Is it a change within this triangular shaped meniscus within the knee? Is it due to synovitis or inflammation, similar to what Professor Wicks was talking about? And which tissue structure is ultimately responsible for the development of osteoarthritis? Because we don't know as yet. So this is one of the research areas we're currently focused on. Another area where there's a lot of international effort going on, and we're doing some trials on this at the moment, is that area of disease modification. So to me, again, joint replacement is a wonderful procedure if you need it, but for me, long term, I think there's better ways potentially of managing that. So we're trying to develop agents, many of which will potentially be injections you receive into the joint that will actually help to preserve the joint tissues and hopefully help to regenerate those. So this is some of the international efforts and some of our efforts to focus on developing agents in that regard. For many of you who have osteoarthritis, you probably know this, that your pain in osteoarthritis fluctuates over the course of time. And why that fluctuates isn't particularly well known. So again, the NHMRC is sponsoring us to do a study where we're specifically looking at a whole range of different risk factors. Whether that's wearing high-heeled shoes, yeah, I know they're aesthetically pleasing, but they're probably not really good for your knees. Whether that's due to joint injury, whether it's due to mood, activity, weather, or alteration in your medication, and whether those things are responsible for alterations in the symptoms that you feel. So that's another area of research that we're currently focused on. How am I doing for time? Do I have a minute?
Yeah, you've got 5 minutes.
Got 5 minutes. So as you can probably tell, I get a little bit disturbed about lots of things, but particularly about inappropriate management of osteoarthritis. So this is something that we've launched relatively recently with Arthritis Australia in an effort to see if we can actually improve the management of osteoarthritis in the community. And it's what we're calling My Joint Pain, and this is just a brief video portrayal of how you might use that if that's something you wanted to use.
If you're experiencing pain or discomfort in your joints, you may have osteoarthritis, also called OA. While it's a common disease, OA is often misunderstood. It's not just an old person's disease. It can affect people of all ages. And while it can't be cured, something can be done. This new, easy-to-use website can help you ease the symptoms of OA or joint pain and help you lead a more active and pain-free life. Developed by Arthritis Australia and medical experts, it features a range of online tools and in-depth information to help you. To start, we'll ask you a few questions about where you feel any discomfort or pain, some other health-related questions, and what you're currently doing to manage any joint pain. This will create a customised plan that can help you reduce some of the symptoms affecting your quality of life. Let's work together to slow down your OA and to manage your condition. There's no cure for OA yet. We're working on it. But in the meantime, there's myjointpain.org.au. To get started, just click on the green button on the homepage.
So that's something that's launched relatively recently, and it's available to anybody who wants to use it. And a lot of what I've spoken about tonight, it provides more information about ways to manage osteoarthritis. But ideally, from my perspective, puts in the hands of anybody who has osteoarthritis the tools that they can use to inform themselves about the disease and how best to manage it, as well as monitoring it. So for any of you who have osteoarthritis, I'd encourage you to use it. I don't earn any money from it if you're wondering, but it's out there for you to use. So from an evolutionary standpoint, there's lots of ways we're changing. Not all of them are necessarily beneficial for our joints. And from a perspective of a researcher, I think there's a great load that I bear, but a greater load that those people within the community that have osteoarthritis bear by virtue of the disease that they have. Now, there's lots of opportunities we have with regards to trying to change the way that disease is managed. So again, I get very disturbed about how inappropriately this is managed in the community, but I'm trying to put out there, both for patients, but also in the very near future for GPs, better tools to enable them to better manage this disease. The reality is, and I think the bottom line message I really want to focus on, is we really need to focus much more on modifiable risk factors. So that's really where I wanted to focus on weight loss, exercise, correcting the mechanics of the lower extremity by fixing feet and knees and the alignment of those joints themselves. That's the Arthritis Research Council. I'm not entirely sure what happened there. But I'd like to thank all of my collaborators, and I have the wonderful opportunity to work with a lot of great people doing research as well as clinical work. And I'm supported by lots of people throughout the world in doing research. And I think we ask questions later. Is that right? Yeah, thank you.
So I'll ask Professor Wicks and Professor Hunter to take the comfy chairs down the end there, and we'll have about 15 minutes of questions, and then you'll all be welcome to have some refreshments outside afterwards. So I'll kick off and take the chairman's privilege to ask the first question, and that's to you, David. Professor Wicks talked about the value of some of the animal models that allowed people to, identify the role of potential targets for personalised treatment. Are there any good animal models of osteoarthritis?
Is anybody here a preclinical animal model researcher in osteoarthritis? Good. There are a number of good animal models for osteoarthritis. Many of them, unfortunately, though, are just injury models. So they usually relate to transection of a cruciate or a meniscus. And not many of them are what we would consider the typical normal development of osteoarthritis in the general community, potentially with the exception of the Duncan Hartley guinea pig. So there are a lot of them that have been developed, but unfortunately, the translation of often very promising findings from a preclinical animal model into the human setting hasn't necessarily panned out particularly well. And so that there is always a lot of opportunities to develop better models and ones that mimic the human disease a whole lot better.
Oh, okay. Yeah. Okay, I have a question for Professor Wicks, or also maybe for Professor Hunter. Professor Wicks said the immune system says something is wrong and goes in to do something about it. What are your thoughts about what might be wrong? And with the advances that have been made in detection of our colonisation by bacteria, do you think it possible that there are bacteria there that the immune system can find, but microbiologists can't?
Yeah, no, I think it's it's an intriguing question, and people have been exercised by it for a long time. So there has been a lot of effort over the years in trying to identify a microbial trigger for rheumatoid arthritis, and at various stages this has had quite interesting outcomes. There were fads for removal of all teeth in the treatment of rheumatoid arthritis. The thought at the time was that there was chronic gum infection. There was a fad for removing the colon, and the thought was that once again there might be abnormal bacterial growth in the lower bowel, and obviously unfortunately those things fell by the wayside. So people have looked and have tried very hard. As you say, methods are improving all the time, and so I think we have to keep an open mind. As I'm sure you know, for a long time people thought peptic ulcer disease had nothing to do with infection, and then it turned out that it did. So I think people are keeping an open mind. Technology is improving, and so it will remain an open question. One interesting extension of the idea is that our diet might kind of set the rheostat for inflammation. And there's a lot of work going on in that area at the moment. So it's not so much a specific infectious organism, so much as the balance of organisms that our diet tends to regulate. And so it seems that the Western diet is pro-inflammatory, as people put it. So that the features of that diet mean that the system is more geared towards an inflammatory response, that more reactive substances are are built up in relation to our diet. So there is a lot of work going on at the moment that might go down that track of dietary modification, but in a global sense, in the sort of public health sense, perhaps more towards, say, the Mediterranean diet, which we know is anti-inflammatory, that sort of direction. I think that could well have a significant impact. But at the moment, we, in spite of looking very hard, we don't have a definite infectious trigger. Lots of potential candidates, but I'm not sure we know exactly when to look. Rheumatoid arthritis may start when you're very young, but then the immune system takes a long while to gradually get into this wrong track before you actually present to a doctor with symptoms. So it's very hard to know exactly when things start and when it might be the best time to look.
The lady.
I'm interested in the long-term use of anti-inflammatories for osteoarthritis. I understand that there are problems taking it for long-term use, but on the other hand, you get wonderful benefits from it. So I would like you to comment on that, please.
It's a really important question, and I think it's important to understand that about 30 to 40% of patients who have osteoarthritis are on an anti-inflammatory, and any anti-inflammatory carries with it risks. The most common of which relates to the fact that it blocks an enzyme that's important for mucosal preparation in your stomach. So it increases your risk of ulcers in the stomach. More recently, some studies have also demonstrated that all anti-inflammatories, potentially with the exception of naproxen, also increase your risk of vascular events, heart attacks, strokes, and things of that nature. So just before you get too worried about that, so the absolute risk is about 1% over the course of a person's lifetime. Okay, so 1 in 100 people will be affected by one of those, and the increased risk is about 30%. So it increases it to 1.3%. Okay, so if your background risk is about 1% of having a vascular event during the course of your lifetime, it increases that by 0.3%. But it is measurable, it's meaningful, and if you have a background history of heart disease or high blood pressure, I think it's important you be cautious about them. But I think if I extend your question out a little bit, people who are on anti-inflammatories, who are having regular occurrences of flares of their pain, a lot of people who take anti-inflammatory take them for very short intervals. And if that's sufficient to control your pain, that's fine. As Professor Wicks said, these don't modify the course of your disease. But if you're having regular persistent episodes of pain, the anti-inflammatories, if you're on them as a chronic background dose, actually help to reduce the frequency of what we call your flares. But again, the longer you're on it, the higher the dose, the more chance you have of side effects from them. So it's important you try and balance that against the benefits that you do redeem from them. So they are very efficacious drugs with regards to relieving your pain, but they do carry with them some real risks.
Is there anything you can do to mitigate that?
Sure. So, a couple of the things you can do is make sure that you don't take more than one anti-inflammatory at a time. Another thing you can do is take them with food. If you have a history of any problem with your stomach at all, with regards to ulceration, it's probably advisable you don't take a non-specific anti-inflammatory and you go for something that's likely to be safer. Again, I'm not here to promote any particular agent, but something like meloxicam or Celebrex is likely to be safer, and or using something to help protect your gut.
Probably for you, Professor Hunter. I work predominantly with the aged population over 70, of course, obviously a lot of osteoarthritis. There's a lot being recommended regarding some of the more experimental treatments of things like stem cell injections and cortisone injections. Just wondering what research has been around those things.
All right. So how many of you have had stem cells? Good. All right, so I'm a little bit of a heretic as far as rheumatologists are concerned. A lot of rheumatologists inject a lot of joints, particularly knees, with steroids for osteoarthritis. The best current evidence would suggest that it provides a mean duration of relief of about 1 to 2 weeks. Now, when we think about the fact that this is a disease course that lasts about 30 years, to me, 1 to 2 weeks doesn't necessarily cut it. So I much prefer patients to focus on other aspects of management that are likely to make a meaningful difference to the disease course longer term. So that puts steroids in their context. So there are a couple of rare instances where I might use intra-articular steroids, and that's if a mother comes along to me and says, I want to walk down the aisle without a limp at my daughter's wedding next week, and I need some relief. In that instance, then I might be convinced. So that's for osteoarthritis, and it's very different to the inflammatory types of arthritis that Professor Wicks was talking about. For stem cells, they're a fascinating idea and potentially will make great inroads down the track. But the best current evidence is in animals. And from the viewpoint of translation to humans, the only small trial that I'm aware of that's been done, we did, comparing it to saline, and did not find any difference at 6 months in terms of symptom improvement. So again, it's appealing, but it shouldn't cost anybody any money at the moment, and it's costing them $10,000 a piece to do it. And at best present evidence, it would suggest it's no different to saline. So the reason I say it's appealing is because I think if we can correct the mechanics of the joint and then inject something to help to regenerate the joint tissues, it might have an opportunity to work. But at best, at present, it doesn't necessarily provide any meaningful therapeutic benefit. So I'd really encourage patients to focus on things that make a meaningful difference to the disease course longer term.
In the context of musculoskeletal health, in particular with junior sport and prepubertal kids who, not so much from the point of view of trauma, but rather over repetitive exercises such as tennis serves. All my grandkids are running 3 kilometre cross-country runs. They moved up to the national titles and things. And I have some concern at the prepubertal level that there may be damage right down the track in the fact that the epiphyseal plates aren't complete and all that sort of thing. Are there any guidelines that can be given perhaps to people who run junior sport programs where this over-repetitive type of thing, whether it's swimming but not so much impact activities, but over-repetitive type activities?
Yeah, I mean, it's a really important question, and from a public health standpoint, there are no specific set guidelines that provide any strict criteria about either how many sports, what duration of sport per week that different kids at different levels participate in. I mean, I know lots of kids who are participating in 3 different competitive teams every week. You know, they play in their school team, their club team, and their rep team. The reality is, particularly when there's not so much variety around the sporting activity, and it's very monosyllabic with regards the type of focus of the activity, we are seeing an increasing number of overuse injuries amongst young kids. Historically, the big concern about premature closure of plates more related to high weight training, and it hasn't necessarily borne out. I'm not encouraging any young person to go out there and do high weights at a premature age before their plates close, but that hasn't necessarily borne out. So I guess in direct response to your question, there are no strict criteria. We're seeing a lot more injuries related to that, and I think we're going to see a lot more before those strict criteria come out, unfortunately.
So the next question from the middle, and then can you pass the microphone right up the back there?
Oh, okay. No, just can I make
Yep.
quick question about, you've mentioned knees, other joints, but what about spinal osteoarthritis and what you can do for that? Because it's not necessarily going to be a weight issue, is it, at that point?
So weight does play a role, but unfortunately injury and genes are the predominant risk factors there. So for all of your joints, genetic predisposition plays a role. So for hip and hand osteoarthritis, about 50% of a person's likelihood of developing that is related to genes. For your spine, it's about 70%. Injury also plays a role, as does occupational risk, as does weight. So all of those things do play important roles. From the viewpoint of modifying risk factors for disease, again, for the back, we tend to focus on, again, weight, core stability, and ergonomics. Oh, so it's your neck. I thought you were talking about your low back. But again, for the neck, ergonomics and posture are still incredibly important. So do you have a predominantly office-based desk position? Yeah. So again, genes are important in terms of predisposing as to why that's happened. Weight can play a role, but again, ergonomics within the office environment is a really important predisposing risk factor. So if you haven't already, talk to someone who's practiced in ergonomics. Make sure you get up on a regular basis through the course of the day. I know that it probably sounds very disruptive, but every 20 to 30 minutes, make sure you don't sit there for long periods of time, keep moving. And by all means, make sure that you don't do what I do towards the end of the day. Yeah. The more protracted your head is, the more stress you put on your neck.
So we'll just have a couple more questions. The first one from right up the back, and the next one, the last one will be right down the front.
Right, a quick question for Professor Hunter. Osteo injuries you were talking about, are spurs or so-called spurs a first indicator, or are they something sideline which you can wear out?
So what we call osteophytes, which are basically bone, yeah, I think I'm referring to the same thing, I'm not entirely sure, but bone and cartilage that typically forms at the margin of the joint, but can also form in the center of the joint, is your bone trying to repair itself. It often occurs reasonably early, and unfortunately it's not particularly functional. It occurs usually at the margin of the joint, and it usually is done to assist the spread of load and the dissipation of forces across the joint, but it's usually an early part of osteoarthritis. It usually occurs before you've got gross loss of joint space on an Xray or altered malalignment, and it's your body trying to repair itself, but it doesn't do itself in a particularly functional way.
And now there are two more questions, right up the back, and the last one will be down the front.
Hello, I'd just like to check the acid-alkaline balance of your body with regards to good water hydration. I see nothing or no studies with regards something along those lines, especially with regards the medications that do so much damage to the stomach and bowel.
It's more like incense.
So acid and alkaline balance is potentially important for the management of particular types of crystal arthropathy, specifically gout. So there's a particular type of acid, monosodium urate, which can increase in levels and predispose to gout. And there are certain aspects of the diet, particularly purines, which get broken down into that. And so the acid-alkaline balance in that disease can play an important role. A lot of people swear by diets that are elimination diets or extreme diets that get rid of specific foods. And one of the common foods that people eliminate in their diet are citric foods and other acidic foods for osteoarthritis. I've never seen any evidence of benefit of that or any trials to support that that's actually advantageous. I think it's, from a dietary perspective, from my perspective, it's most important that the diet be well balanced, and that if a person is overweight, that they try and restrict the caloric intake.
The last question from the front there.
I'm wondering if emotional trauma has any role to play in osteoarthritis, seeing that the immune system's attacked.
In rheumatoid or osteo? So I'll comment on osteo, and then I'll pass along to Professor Wicks to comment on rheumatoid arthritis. Depression, stress and anxiety play a really important role in the perception of pain and the management of a person's pain. As I mentioned, about 30% of our patients with osteoarthritis have what we call clinical depression. It's often not recognised, and unfortunately still, despite the efforts of Beyond Blue and other campaigns in our community, depression still carries with it a black tag, and people aren't necessarily happy to talk about it. For me, if a person has osteoarthritis and depression, I need to treat the depression in order for their pain control to be more easily managed. So it plays an incredibly important role. I think your question might pertain more to the development of osteoarthritis. Yeah.
In early childhood?
Not that I'm aware of.
Right, so there's still a couple of tasks. Oh, sorry, you were going to talk about it?
Only to say, if you're referring to rheumatoid arthritis, that everything Professor Hunter said applies potentially even more so. I think in rheumatoid arthritis the patient is typically a bit younger, And if the disease isn't controlled, there can be these major impacts on the ability to work, to take care of family, to do all of the normal activities at a stage in life where that has multiple consequences. So we find that depression's very common in rheumatoid arthritis, and there's no doubt that it amplifies symptoms. And we can have quite commonly have a situation where we think on objective clinical measures the arthritis is under reasonable control, but the patient is still experiencing a lot of distress. And so I think it's very important in those situations to get the distress, psychological distress, depression, acknowledged and effectively dealt with, because it can have a major impact, compounding what's going on underneath with the rheumatoid arthritis.
So there are three things we've still got to do. First of all, I've got to remind you all to fill out one of the questionnaires before you leave. And the more people that fill out the questionnaires, the better, because that'll help us improve these seminars in the future. The second thing is to remind you all that there are going to be some refreshments outside, and I'd like you to join us there, and you'll have another opportunity to question our guest speakers. And the last thing is to thank them both very much for their excellent presentation.